Hi there, my name is David Beaton and I'm a gastroenterology registrar currently working in North Tees and Hartlepool NHS Foundation Trust. Alongside Dr. Joseph Beintaris and Professor Matt Rutter, we recently produced a paper titled Utilization and Reproducibility of World Endoscopy Organization Post-colonoscopy Colorectal Cancer Algorithms, a retrospective analysis. Ever since the World Endoscopy Organization released their consensus statements regarding post-colonoscopy colorectal cancer, there's been an increased focus in this field. Much of the subsequent study has looked upon rate calculations, looking at different post-colonoscopy colorectal cancer rates regionally, nationally, within different settings and in different patient cohorts. Alongside these rate calculations, it's vital that we review these cases locally with the intent of reducing the rates going forward. To this end, the World Endoscopy Organization included in its statement the recommendation that as cases are identified locally, they should be reviewed and categorized according to their most plausible explanation and into interval and non-interval subtypes. The most plausible explanation categorization really centers upon the likely cause of the post-colonoscopy colorectal cancer, and we can highlight these and hopefully drive cases down by understanding a bit more about them. Categorizing into interval and non-interval subtypes looks more at the appropriateness of screening and surveillance intervals, while also identifying how robustly and appropriately these intervals are being followed locally, and as such, testing clinical decision-making and local admin factors and try to identify any causes which might contribute to post-colonoscopy colorectal cancer cases locally. Our aim was to test the utilization and reproducibility of these algorithms in a clinical setting, identifying any issues and difficulties that we encountered, and exploring the logistics of performing them on identified cases. What we found was that review of post-colonoscopy colorectal cancer cases could be performed accurately at a local level using readily available clinical information. Categorization into most plausible explanation was possible, and we had almost perfect interobserver agreement when this was performed. Categorization into interval and non-interval subtypes was more challenging, often reflecting the fact that national screening surveillance intervals have some ambiguity within them. Interestingly, when we reviewed the outcome of our algorithms and analysis on local cases, we identified that a significant proportion of cases were categorized as non-interval type B. This indicates that by improving our adherence to national screening and surveillance guidelines, we could hopefully reduce a PCR rate, CR rate going forward. This indicates that by improving our adherence to local and national screening and surveillance guidelines, we can hopefully reduce our post-colonoscopy colorectal cancer rate going forward. Many thanks.